Chronic pain can drastically reduce the quality of life and is often resistant to medical therapies. Opioid medications are addictive and they've got the potential to ruin lives if they're not used sparingly. The excessive use of non-steroidal anti-inflammatory drugs like ibuprofen increase the risk of many health problems. A supplement called pamethylethanolamide, or PEA, has been shown in several clinical trials to reduce the pain due to a variety of causes. The PEA modulates the inflammatory signaling and it interacts with the body's endocannabinoid system, but it doesn't cause any psychotropic effects. Chronic pain, unlike acute pain, can last for months or even years. The chronic pain can drastically reduce the quality of life, and unfortunately, it's not always easy to determine the factors that are contributing to the pain. Conventional medical treatments are wrought with adverse side effects, such as opioid addiction. Even over-the-counter drugs have been linked to adverse effects. Acetaminophen overdose is the leading cause of acute liver failure in the United States. Pain can broadly be classified as nociceptive or resulting from the activation of peripheral pain receptors, or neuropathic, resulting from injury or dysfunction in the nervous system. Nociceptive pain is intrinsically linked with inflammation, while neuropathic pain may be more difficult to treat. Natural interventions such as Honocchiol and PEA might help to relieve the pain without the adverse side effects that are common to the pharmacological pain therapy. Some non-pharmacological pain therapies are exercise, behavior therapy, meditation, and biofeedback. The drug-based options are the non-opioid pain relievers like acetaminophen and non-steroidal anti-inflammatory drugs. Opioids, antidepressants like tricyclics and serotonin norepinephrine reuptake inhibitors, anti-epileptic drugs like gabapentin, muscle relaxants like benzodiazepines, and topical analgesic agents. Several types of dietary intervention have been linked with pain relief, like periods of fasting, low glycemic index diet that's high in protein and low in carbohydrate, vegetarian and vegan diets, and diets that are rich in antioxidants like fruit and vegetables. Honocchiol is a polyphenol and it's extracted from the bark of magnolia trees. It's long been used to improve sleep and to relieve anxiety, and it can be helpful to relieve inflammatory pain. A lipid present in the tissue around the body may be effective for relieving pain from many causes without adverse side effects. Many clinical trials have demonstrated PEA's effectiveness in this area. A greater dietary intake of omega-3 polyunsaturated fatty acids has been linked to a reduction in both inflammatory and neuropathic pain. Gamma-linoleic acid, a plant-derived omega-6, helps to modulate inflammation throughout the body. It's been shown to relieve pain from a variety of conditions. It's found in evening primrose oil and borage seed oil. Vitamin B1, B6, and B12 are beneficial for many painful diseases. A mixture of these vitamins has also been shown to reduce neuropathic pain. Evidence suggests that free radicals play a role in exaggerated pain hypersensitivity. Several animal and clinical studies indicate that vitamin C can help to relieve the nociceptive pain. Vitamin T metabolites help to inhibit inflammation. A deficiency is linked with several painful conditions. The administration of vitamin D was found to reduce pain for women with chronically painful periods, and it might help to relieve pain from other causes. Curcumin has been shown to have analgesic effects, and it might be useful for a variety of pathological pain conditions. It reduces the levels of inflammatory mediators that are involved in nociceptive pain hypersensitivity. Ginger has analgesic and anti-inflammatory properties. Certain species can be helpful in reducing pain from muscle sprains, arthritis, menstruation, and other sources. Aside from its well-known role as the sleep hormone, melatonin is also a potent antioxidant, and it's been shown to reduce the pain that's associated with a variety of chronically painful conditions like fibromyalgia, irritable bowel syndrome, and migraine. Additional natural compounds that might be helpful for managing chronic pain include vitamin E, proanthocyanidins from grapeseed, and MSM. The sensation of pain arises in the nervous system. It has a variety of causes, but the experience of pain is variable and subjective. Pain can be both acute and chronic. Acute pain is a protective mechanism and it makes you aware of an injury. In contrast to acute pain, chronic pain is persistent and it can last from months to years. Chronic pain can drastically reduce the quality of life. We know that 79% of chronic pain patients report disruptions in daily activities, and 67% indicate that chronic pain negatively impacts their personal relationships. Chronic pain is often resistant to conventional medical treatments, and moreover, pharmacological pain management of chronic pain is hindered by grave long-term side effects. Opioids are wrought with adverse side effects, and they have significant addiction potential. But poorly appreciated is that even over-the-counter pain medicine like acetaminophen and ibuprofen are linked with liver damage, kidney damage, and even heart attack. Acute pain follows a predictable, finite pattern, and is generally short-lived, self-limiting, as well as easy to diagnose and treat. Pain that persists for longer than 3 months and is not progressively better is referred to as chronic. It can be difficult to pinpoint the exact factors that cause chronic pain to persist over time. Although there's many ways to organize different types of pain, one of the most popular and accepted schemes utilizes the following 8 classifications to differentiate the pain complaints. The pain can be classified by severity, like mild, moderate, or severe. The duration, being acute or chronic. The location, like lower back, abdomen, or head. The origin, like nociceptive or neuropathic. The body system, like the muscular, the neurologic, or the skeletal system. The mechanism, like the central or the peripheral. The diagnosis, like cancer or non-cancer. And the response to treatment, like opioid responsive or opioid resistance. There's 2 major categories of pain, nociceptive and neuropathic. Nociceptive pain guards the body against a potential injury. It occurs as the result of the activation of the peripheral pain receptors called the nociceptors, and these are activated by an injury. The stimuli is converted into an electrical signal, and this is conveyed along the nerve cells into the spinal cord or the brain, where it's perceived as an unpleasant sensation. Neuropathic pain occurs as a consequence of either an injury or a dysfunction in the nervous system. It produces a variety of unusual pain sensations, and it's been described as burning, crushing, and pins and needles. Unlike nociceptive pain, neuropathic pain often persists for prolonged periods of time, even after the original trauma or the dysfunction is addressed. Since neuropathic pain is more complex than nociceptive pain, it's consequently more difficult to treat. Inflammation and nociceptive pain go hand in hand. Inflammation is initiated upon a tissue injury, and it sets off a cascade of biochemical reactions that prime the nervous system for pain sensing. Moreover, long-term inflammation reinforces adaptive changes in the nervous system that can cause the sensation of pain to become exaggerated or inappropriate. For example, inflamed tissue, like an arthritic knee, might be excessively tender, or even a light touch might cause a pain. Nociceptive pain does not occur spontaneously. It needs to be triggered within the nervous system. This is accomplished by specialized receptors called nociceptors. When you experience an injury, several inflammatory mediators like prostaglandins, tumor necrosis factor alpha, interleukin-1 beta, and interleukin-6 are released at the site of the injury, and these interact with the nociceptors, facilitating the transmission of pain signals to the nervous system. If you have a chronic inflammatory condition like osteoarthritis, then increased levels of inflammatory mediators at the affected site, example a joint, as well as systemically, predispose you to the increased pain sensation. Therefore, taking steps to ease the inflammation is an effective means of interfering with the process of pain sensation. This is why drugs like acetaminophen, the active ingredient in Tylenol, and ibuprofen, which are anti-inflammatory in nature, relieve pain. Unfortunately, these drugs and others like them are very effective for reducing inflammation and pain, but they often cause alarming side effects, and this compromises their long-term risk versus benefit profile. A variety of natural anti-inflammatory compounds are able to target inflammation by reducing the synthesis of the inflammatory mediators or by modulating the inflammatory pathways. The scientific approach to pain management demands a stepwise approach which utilizes low-risk interventions first. In many cases, these low-risk interventions are helpful for relieving chronic pain. For example, a recent review found that exercise and behavior therapy was effective at decreasing pain and increasing the functioning among patients with chronic pain. Other non-pharmacological interventions that could be useful for the chronic pain include meditation, biofeedback, acupuncture, electrical stimulation, and surgery. Pharmacological therapy is one of the most popular treatment options for managing chronic pain. While initial treatment recommendations will vary based upon the diagnosis, such as nociceptive versus neuropathic, the most commonly used agents are the non-opioid analgesics like acetaminophen or the non-steroidal anti-inflammatory drugs. The opioids, the antidepressants, the anti-epileptic drugs, the muscle relaxants, and the topical analgesic agents. In an effort to relieve suffering, many chronic pain patients turn to over-the-counter analgesics like acetaminophen or non-steroidal anti-inflammatory drugs. However, since these drugs do not require a prescription from a doctor, patients may incorrectly assume that they don't need to be as careful about dosing them as they would with a prescription analgesic. Therefore, it's important for chronic pain patients to become educated about the most serious adverse side effects that occur with the popular non-prescription analgesics. Since it was first marketed in 1955, acetaminophen has become one of the most widely used analgesics in the US. In 2008, approximately 25 billion doses of acetaminophen were sold. Although the acetaminophen can be safe when used appropriately, it can also be extremely dangerous. For example, unintentional acetaminophen overdose is responsible for approximately 15,000 hospitalizations each year, and it's the leading cause of acute liver failure in the US. You should not exceed the maximum of 4 grams per day. Remember that many prescription pain medications also contain acetaminophen. Recognize that acetaminophen is also called APAP paracetamol or acetyl para-aminophenol. Don't use it with other non-steroidal anti-inflammatory drugs without a medical consultation, as this can increase the risk of kidney toxicity. And don't take it with alcohol, which also increases the risk of liver toxicity. Non-steroidal anti-inflammatory drugs like ibuprofen and naproxen can significantly reduce pain associated with a variety of conditions. However, non-steroidal anti-inflammatory drug use is associated with significant adverse effects like gastrointestinal bleeding, peptic ulcer damage, high blood pressure, edema, kidney disease, and heart attack. For example, the long-term use of non-steroidal anti-inflammatory drugs can lead to impaired glomerular filtration, renal tubular necrosis, and ultimately chronic renal failure by disrupting prostaglandin synthesis, which can impair the renal perfusion. Even in non-steroidal anti-inflammatory drug users without overt kidney dysfunction, subclinical irregularities in kidney function are sometimes observed. Aspirin, a type of non-steroidal anti-inflammatory drug, is commonly used to treat minor aches and pains, as well as being prescribed at low doses for heart protection and stroke prevention. Aspirin irreversibly inhibits an enzyme called cyclooxygenase 1, or COX-1, in the platelets, which is why it poses a greater risk of bleeding, such as a hemorrhage, than other non-steroidal anti-inflammatory drugs. Therefore, patients taking aspirin should avoid the simultaneous use of anticoagulant drugs and alcohol. In addition to bleeding, the aspirin can also cause side effects such as heartburn, nausea, vomiting, stomachache, ringing in the ears, hearing loss, and a rash. Despite the wide variety of pharmacologic therapies available for patients with chronic pain, a recent report published by an international panel of experts has pointed out that current conventional treatment schemes are lacking in efficacy and they often impose unacceptable side effects. For example, opioids are the most commonly prescribed class of medication in the US for short-term relief of chronic pain, and yet their efficacy and their negative side effect profile have many experts questioning their use in this way, especially since the increase in opioid availability has been accompanied by an epidemic of opioid abuse and overdose. In addition to the potential dependence, patients on opioid therapy should also be aware of other common side effects, such as constipation, nausea, excessive sleepiness, itchiness, headache, and respiratory depression. According to the World Health Organization analgesic ladder, opioids are not recommended for chronic pain unless the pain can be described as moderate to severe and/or has not responded to previous non-opioid treatment approaches. Consensus expert guidelines only recommend opioid therapy for managing chronic non-cancer pain once all other reasonable, low-risk and low-cost pain management interventions have failed. In an effort to reduce the risk of serious adverse outcomes associated with narcotic pain relievers, Congress recently mandated that the FDA create the risk evaluation and mitigation strategies. This requires the drug companies to develop special educational programs for physicians and for patients who are prescribed these potentially dangerous medications. While opioid therapy can be used for chronic non-cancer pain in a safe way, it must be initiated properly and only in select patient populations. Evidence linking long-term opioid use to a decline in endocrine function and subsequent hormonal imbalance has been accumulating for some time now, but recent data has garnered renewed attention. The molecular structure of opioids make them well equipped to interfere with the normal function of the endocrine system. Evidence suggests this influence occurs in the hypothalamus and the pituitary gland brain regions, and the gonads, or the reproductive organs. The opioids tend to decrease gonadotropin-releasing hormone and the secretion from the hypothalamus, in turn decreasing the release of luteinizing hormone and follicle-stimulating hormone from the pituitary gland. This upstream disruption has significant implications, especially concerning the ability of the endocrine system to produce additional hormones that rely on steady levels of gonadotropin-releasing hormone, luteinizing hormone, and follicle-stimulating hormone. As a result of this hypothalamic pituitary gonadal axis suppression, the long-term use of opioids is associated with the development of hypogonadism. Opioids have also been known to reduce testosterone levels, which is associated with increased cholesterol and decreased insulin sensitivity. Fortunately, most of these abnormalities can be identified through hormone level testing, as well as patient history and physical examination. Common endocrine-related problems associated with long-term opium use are decreased body hair, infertility, adrenal dysfunction, decreased libido, decreased growth hormone, osteoporosis, miscellaneous hormonal abnormalities, depression, erectile dysfunction, and missed menstrual periods. The three main therapeutic options available for patients experiencing these side effects are switching to a different type of opioid, example, opioid rotation, switching to a non-opioid analgesic, or to initiate hormone replacement therapy. A recent study among male chronic pain patients concluded that long-term testosterone replacement therapy was associated with an increased quality of life and decreased pain rating. Chronic activation of peripheral pain sensors, the nociceptors, such as occurs in osteoarthritis, for example, can alter the central neural pain processing over time. The ongoing nature of chronic pain and the adaptive nature of the central nervous system both contribute to biochemical alterations that increase pain sensitivity and cause the brain to become accustomed to processing pain. This phenomenon is known as central sensitization. When the central nervous system has become sensitized to pain, painful sensations can be augmented because they're no longer only a nociceptive response, but they're now being reinforced by mechanisms within the brain and the spinal cord. Thus, chronic pain has a peripheral and a central element. Evidence shows that patients with osteoarthritis of the knee are more sensitive to pain at other sites on their body than a healthy control. This is because the brain of people who are afflicted with chronic pain have adapted to processing pain and have become hyperresponsive to painful stimuli. The central element of chronic pain doesn't respond to traditional therapies, such as anti-inflammatory drugs, because they can't modulate the transmission of pain within the sensitized central nervous system. Therefore, drugs like antidepressants and anti-epileptics can complement traditional anti-inflammatory drugs by modulating the central biochemistry. In the case of antidepressant drugs, it appears the mechanism by which they provide pain relief is somewhat independent of their mood-altering effects, while anti-epileptics alter the pain signaling by modulating the calcium signaling in the brain, which is also a mechanism by which they control seizures. For many people with chronic pain, centrally acting drugs are effective adjuvants to traditional pain therapies. Moreover, because central processing is a critical element of neuropathic pain, centrally acting drugs are a mainstay of treatment in this setting. Recent evidence suggests certain types of dietary intervention might have significant effects on chronic pain, especially severe forms of chronic pain. Also, chronic pain can result in a decreased protein intake and increased sugar and starch intake, and these dietary changes result in wasting. Although the exact parameters of the anti-pain diet have not yet been recommended by any clinical organization, the scientific literature contains plenty of data indicating a strong link between food and pain. For example, periods of dietary fasting have been linked to temporary relief of pain among many patients. For long-term pain relief, some experts suggest a high-protein, low-carbohydrate diet, such as a low glycemic index, which has been associated with decreases in pain sensitivity and inflammation. Likewise, several studies have shown a vegetarian-vegan diet is also beneficial to patients with chronically painful conditions. Consuming a diet rich in antioxidants may also be helpful to relieve chronic pain. This is because the antioxidants neutralize the free radicals and the oxidative stress, which plays a significant role in persistent pain conditions, and it's been linked to an increase in pain sensitivity. Some researchers believe that many of these dietary interventions activate the endogenous opioid system, which is the body's natural defense against pain. Moreover, documenting dietary history to ensure adequate protein intake can help chronic pain patients avoid muscle loss and weakness. For more information about herbs, supplements, and natural treatment plans, check out my website.